Good afternoon, everybody. My name is Stuart Schlossman. For those that don't know, I'm president and founder of MS Views and News. And for those that don't know, I too have multiple sclerosis. And that's why I began doing all that we are doing. Once upon a time, I was attending a support group right after I was diagnosed and found that there were only a few people in the support group that actually knew how to use the internet and find out what was going on with themselves. But being internet savvy, I was able to get on, find the information, and start sending it out to that support group, and then it led out to other support groups. And what started as just 5 people, just take the short version, what started as me sending out information to just 5 people now reaches people in over 90 countries, and over 35,000 people are receiving this from us each month. So then we became MS Views and News. Started at Stu's Views and MS News, and then we became MS Views and News. And now we're here today to thank those that gave us the dollars to do today's program. And again, I will thank Genzyme, a Sanofi Company, Biogen IDEC, Mallinckrodt, Genzyme. Again, I will say Accorda Therapeutics and Teva Neuroscience. So we want to give them all a round of applause and thank them for doing for us. Today's speaker for this program is Connie Easterling, and Connie is here to speak with you about different treatment options. Now we have 11 of them on the market. Can you imagine that? We have 11 different medications for you to try out. You don't like one, switch it? No, don't switch that fast. She's going to talk to you about adherence and compliance. This is a topic that's extremely important for you all to listen to, all right? So we want you to listen to that. And she'll speak with you about the invisible symptoms of MS. She'll do Q&A. We'll have our special guest come in. You could be jolly with this person or not. It's up to you, all right? And again, I want to thank our volunteers, Pam Porras, Michelle Markman, Lulu. There she is in the back. I don't even remember her last name right now because she's Lulu. And Michelle Markman. And thank you again. Let's get started with Connie. This is your box.
This is my box.
This is your box. You're not allowed outside the box.
I can
lean
here.
You go outside this box, it's like those dog fences, you get shot.
Okay, I'll try not to go outside the box. I don't want to get shocked. It's really nice to be here today. I see some old friends and some new friends. Hey, Tina's here. I didn't get to speak to her. So, oh, hey, some of my patients are here. It's always nice to see all of you, and it's nice that you'd come out on a day like today. I went out, I came, and then I left, and I got soaking wet in the rain. My husband and I made 2 stops Christmas shopping, so I feel so much better. You know how you're looking for that one thing, and you haven't been able to find it? And I found it just a little while ago. So today, Stuart gave me this topic, multiple topics. He said, I want you to speak on this, and I want you to speak for 30 minutes. Well, those of you that know me know that I can't speak on one topic for just 30 minutes. So we'll try to get through as much as we can, and then I'm certainly available to talk to you or answer any questions. And Stuart wasn't quite correct. We have 12 treatments now for the treatment of MS, but we'll talk about those new ones if you really want to. And I did want to dispel one rumor. I got a text from Pam Porras the other day, and she goes, the word is you're retiring, and is that true? And I told her I am cutting back on my hours to 2 days a week, but I'm not retiring. So one of these days I will, but I hope I don't have to tell you guys that I'm doing that. The first patient I told about a month back that I was going to go part-time was a 54-year-old man. And he cried like a baby. So it was so sad for me. So I told the staff I'm not telling another person. So I don't know how it gets out there, but Pam knows. So, it just gets out there. So let's talk about MS. So those of you that have MS, you know what MS is and what it means to you, but it is an autoimmune disease, an immune-mediated disease, and it's characterized by these lesions or scars along the nerve pathways in the brain stem, the spinal cord, and the optic nerves. And the multiple scars is what gives us the name multiple sclerosis, multiple scarring. And so we do know that MS very typically, in most people that have MS, they have relapses, and then they have, sometimes they develop disability over time. One of my colleagues says that MS always leads to some level of disability, and that is true, but although the disability is mild in some people, whereas it's more profound in others. But we really don't know what causes MS, but and I'm going to tell you in a minute, what we think causes MS, but the actual trigger is really different for every person, and that's why MS is so different for every person. We do know that MS is an inflammatory disease. You can recover from those scars, those lesions that occur in the central nervous system. What you can't recover from is the degenerative part of MS, which is a loss of the axons themselves. And many people who have significant disability, we know, have lesions that have been, or have axons that have been lost, okay? I meant to put a picture in here of an MRI, but I think I forgot to. So what causes MS? Well, we know that there's an environmental trigger, we know that there's a genetic component, and there is an infectious component. That infection for Ursula could be Epstein-Barr. For Kathy, it might be HHV6. The environmental trigger may be where Ursula grew up before the age of 15. For Kathy, it may be a low vitamin D level. There's just so many things. And so the genetic component could be come from many generations back. It is not hereditary, like diabetes is an autoimmune disease. It is not hereditary. So, but it is genetic. So you have to have that perfect genetic component, that infectious agent, and then the environmental trigger, and it has to all happen at the same time, and then it starts that cascade of events called MS. And what's interesting about that is these events can come together before the age of 15, and then you may not show any signs of MS till you're 25 or 30 years old. So what causes MS may be different, similar but different in every person, and we know that there are no two people alike that have MS. So we do know that 85% of people with MS have what type? Relapsing remitting MS, that's right. And so they have a relapse, they get better, and if you look at the top line, have a relapse, they get better, have a relapse, they get better. And there may be a time, the longer the time there is between relapses, the better for them. If you have one relapse every 2 or 3 years, your outcome is going to be better than someone who has 3 or 4 relapses in a year. And then some people retain symptoms between relapses, and over time they develop disability. So we don't like to see that. If we had, everybody in this room had relapsing remitting MS, then we would find that 60 to 65% of them would have already transitioned to a secondary progressive phase. And what that means is that they don't have as many relapses, but they have those lesions that developed in the first 5 to 10 years have become a problem now, and they show more disability. And what happens in the clinic is they come in and they say, I'm having a relapse, my symptoms are worse. We do an MRI. The MRI shows no change. And we know that it's what happened in the first 5 to 10 years that's leading to the problems, the level of disability that they have now. So some people have relapses during this time, some do not. They just progress. Now the disability that you develop in secondary progressive may be mild, or it may be more profound. You may start using a cane, you may start using a walker, and that sort of thing. But that's secondary progressive MS. Now, if you have relapses during this phase, then you should be on treatment. Some doctors take patients off treatment during that phase. We tend not to do that because so many people with secondary progressive do have relapses. 10% of individuals with MS will have primary progressive. That means they're moving moving towards a level of disability from the very beginning. They have a new symptom, they keep it. They have another new symptom, they keep it. They never get better. Sometimes they may feel like they plateau. Other times they may feel like they get a little bit better, but they're always moving towards disability. Takes us a long time to identify that type. So you may be diagnosed with MS, and then you go on treatment, and we may not know for 2 to 5 years that this is really primary progressive, and then we'll take you off treatment. 5% have progressive relapsing. They have progressive. They're always moving towards some level of disability, but they may have a relapse or two over time. So the principles of managing multiple sclerosis, you can see here, the overall purpose or the overall plan for multiple sclerosis is what? Some of you have heard me talk about this before. What is the overall thing that we want to do as we treat or we try to manage multiple sclerosis? What? Stop the progression. Now you notice I have up here prevent. We used to say what? Delay progression to disability. That was for, I've been doing this for 17 years, and just up until the last year, we changed it from delay to prevent. And we can prevent it now because some of the new treatments that are out actually can stop the disease, not in every person. We want to stop the frequency and the severity of relapses. We want to stop the lesions that develop in the central nervous system. We want to manage the symptoms, and we want to manage them effectively. And then we want to maintain functional independence for you, keep you as well and as independent as possible. And we want to find treatments that are not only effective for you, but tolerable as well. That's the key. Dr. Clafter, who many of you know works with me, he had a lady he put on one of the interferons years ago, and she was intolerant of it. She was sick all the time. And so I told him I was going to change her therapy. And he says, but it's working for her MS. I said, it's not working for her. So we have to have treatments that are not only effective to stop the disease, but are tolerable to you. And of course, we want you to have a quality of life that's acceptable to you. So, so here I'm going to go ahead and build this slide. I didn't realize that it wasn't totally built. But what are we doing when we start treatment? What are we looking at? So if you look at this, disease onset, the bottom horizontal line is time. This is the level of disability. If we start treatment at the very first event, which is called a clinically isolated syndrome, then we can prevent some level of disability. The disability that will have occurred in 10 to 15, 20 years will be much less than if you start treatment later. In Canada and some provinces in Canada and in England, you don't get treatment when you're diagnosed. You have to show disability before you get treatment. It's way too late then, way too late, because later you're going to have more disability over time. If you don't accept treatment, only 60% of people who should be on treatment accept treatment, and out of that 60%, how many are adherent to treatment? About 50%. And actually it's less. How many people do you think are adherent to getting their labs done and their surveillance done like they're supposed to? 30%. 30%. So some of the drugs that you may be on are risky. Make sure you get your labs done. But so we're not making much of a headway in this disease. The natural course means that if you don't take treatment, you're going to have more disability than the person who takes it later or even takes it from the very beginning. So that's what we want to try to do. Okay, so when we have a patient in the clinic, I'm usually the one that puts patients on treatments. But there's a lot of things we have to consider. The overriding factor is that the benefits of the treatment have to outweigh the risk. We have some drugs now that are very risky to you. And if you have other comorbidities, other diagnoses, then we have to consider that. We have to consider what medications you're on. We have to consider what treatment you're willing to do. If I asked you to do an injection every day, not everybody would want to do that. A lot of people don't want to do injections at all anymore, especially our young people. So we have to look at that. We have to look what's the mode of action? Can this person take this medication? What is our preference? What is our experience? Are they young women that are planning to get pregnant? That's a very important consideration. How much monitoring are we going to do? Do they have entitlement? Do they have insurance? If it's going to require you to have a lot of labs, a lot of surveillance, you may not be able to afford it. So there's a whole lot of things to consider when we're looking at putting someone on treatment. So here are the injectable treatments that we have now. We have glatiramer acetate. There are two types of glatiramer out there, one every day, one 3 times a week. Beta interferon 1A, Avonex, Plegridy, Rebif. Plegridy is relatively new. It came out in November, I think. And we wrote our first prescription then. Plegridy is the same identical molecule as Avonex and Rebif, which are all of those are identical in molecule, but they're given very differently. Avonex is high dose, Avonex is low dose, Rebif is high dose. Plegridy is somewhere in the middle. Plegridy is given subcutaneously twice a month. So a lot of people have opted for that because of the decrease in the frequency of injections. And then we have interferon beta 1B, the very first treatment that came out on the market. And Extavia is made by Novartis, Betaseron is made by Bayer, but they are identical and they're actually made at the same plant. And they are interferon beta 1B. These are known as the what drugs? Platform drugs, because they have been out since, well, one of them came out in 93, but they've been out the longest. We can manage the side effects. They are safe drugs, and we call them the platforms. So then the oral treatments came out. The first one out of the gate was Gilenya. Gilenya is a nice drug. We haven't had a lot of opportunistic infections occur with Gilenya, but Gilenya is a risky drug because it causes an artificial immunosuppression. So it opens up the individual to infection, and then there's a whole nother issue with how it works with other drugs. And in some people, I think there's been close to 50 deaths on this drug because it has an effect on the heart. Then we have Aubagio. Teriflunomide came out, was it 2011, I believe? And we have quite a few people on Aubagio, once-a-day pill. Does it have some problems? Yes. Has some problems for pregnancy. It's the only drug we know of that is spilled in the male sperm. So if men want to father a child, they have to be aware of that and be careful to use a birth control. We sometimes will contract our young women to use a safe and effective means of birth control even for 2 years after they stop the drug, because it does stay in the system a long time. But it works, decreases new lesions by about 80%, so it's a good drug. And then a dimethyl fumarate or Tecfidera, it's a tablet's given twice a day. We are finding now that many people forget the second dose. They are not taking the second dose. This is a drug that is virtually ineffective on 1 dose a day. You might as well not take it at all because it is not effective once a day. You have to take it twice a day. It's a unique drug. It's eliminated by breathing. It's not eliminated in the kidneys or the liver, and it's relatively safe. We did have a patient in Europe develop PML on Tecfidera, but that person had been immunosuppressed for 4 years. Nobody monitored him. Nobody monitored his lymphocytes, and he got PML. So that's very rare. We've not had that in the United States. All of these drugs are excellent drugs. They work very well if you take them like they are prescribed. Okay, and then we have our IV treatments. The first one we had was mitoxantrone. Mitoxantrone is an immunosuppressant that affects the heart almost for a lifetime. You can be off mitoxantrone for 2 years and then your heart is affected by it. Also, it can cause leukemia, treatment-related leukemia. Then we had Tysabri come out, and what's the big thing with Tysabri? PML. There has been a few hundred cases of PML around the globe. However, with good surveillance, monitoring that JCV virus status, Tysabri is relatively safe. And let me say this, Tysabri, in comparison to Limtrada, Tysabri looks like a piece of cake. So Limtrada is the brand new kid off the block. It is a IV monoclonal antibody that's given 5 days consecutively the first year and 3 days consecutively the second year. What does that tell you about that drug that you don't have to take it for a year? It's strong. What did you say? Sir? That's exactly it. It stays in your system a long time. What if you fail on that drug? We don't know what we're going to do because it's going to stay with you a while. We're not sure yet how we're going to manage this drug. This is a drug that you have to infuse over 8 hours. A nurse has to sit in front of you the entire 8 hours, cannot leave your side. 90% of patients on this drug have an infusion reaction. You have to take antiviral medication for days before you try the drug, and there is a strong risk of opportunistic disease. Therefore, the FDA has said, opportunistic disease means cancers, lymphomas, that sort of thing. So the FDA has said that you should not be on that drug unless you have failed at least 2 of the other treatments. So it's a risky drug. It's being put out by Genzyme, and we're going to be going to some classes soon to be able to be certified. We have to be certified in using this drug. So also, what's interesting about Limtrada is about 30% of people that take it lose the function of their thyroid gland. So it is, but that's why it's for people who are going down the tubes and getting worse. So what about relapses? Who wants to define relapses for me? We talk about this all the time. Ursula, you can define a relapse.
It's the worsening of an old symptom, the development of a new symptom, each of which would last at least 24 hours and not reappear since 30 days since a previous relapse.
Very good, Ursula, very good. That's true. And and you know, we get asked this question all the time. What are relapses? People who've had MS 10 years come in and say, I really don't know what a relapse is. So a relapse is a new symptom that you've never had before, a neurologic symptom, or the return of an old symptom, but worse than it was before, in the absence of going to the beach in the middle of the summer and staying out in the middle of the heat at 12 o'clock noon. Okay, what happens when you do that? Core body temperature goes up, as Patty would tell you, 0.5 degree. You're going to have trouble with your vision. You're going to have trouble walking. You're going to have trouble functioning. So we want to make sure that the new symptoms or the return of old symptoms is not due to a pseudo-relapse, meaning your symptoms become worse and come back with a vengeance because you have been in a hot tub, because you have a fever, because you have the flu, because you have a urinary tract infection, you have an upper respiratory infection. And remember, upper respiratory infections have been studied. That's the #1 infection that leads to relapse. So remember that. So this fall, take care of yourselves. If your doctors have recommended a flu shot, take it, but no live vaccines, okay? No live vaccines. So we do want your symptoms to be separated by at least 30 days. MS lesions, new lesions in the brain, will last 3 to 6 weeks. They'll be active for 3 to 6 weeks. So we want a time between symptoms to call them a new relapse, because you can have numbness and tingling on the first day of January. You can have motor weakness on the 20th of January, and then visual changes on the 30th of January. So your symptoms can evolve over a whole 4 weeks. But we have to rule out anything else. So they can evolve over days or weeks. Lesions, as I said, can stay active for quite a while. And the recovery can be quick. Some patients recover in just 4 or 5 days. Others recover in weeks after the onset. And some people take months to recover, even a year to recover. I have a patient now who's still recovering, even though her relapse was months and months and months ago. But we never say never, because one day she may get up and she may feel completely better. It just takes a long time for some people. Okay, so then how do we manage relapses? We can manage relapses, and we're fairly big on treating relapses. If you get up in the morning and you have numbness of your hand, but you can still function, we may wait and see if your symptoms evolve. Because remember, treating relapses, even though it's very important to stop that inflammation, really doesn't change the outcome much. It gets you through the relapse faster, decreases that inflammation and that activity in the central nervous system, but the outcome is usually going to be pretty much the same. So we can treat, a lot of people will say to me, can I have prednisone, the pills? And I can tell you, if you take a prednisone taper, we might as well sit down and have a glass of water. Now, do I give them the prescription for the prednisone taper? Yes, because they have a belief that it's going to help them, and that's very important. So there are times that I try to talk the patient into doing the IV treatments of steroids, and they'd prefer to do the prednisone. In Canada, they don't do IV Solumedrol anymore. They do 1,250 milligrams of prednisone, divided up, 25 tablets in the morning, 25 tablets at night, crush it up, mix it in an orange slush, and they actually drink it. Now, I can tell you I had a patient do that recently, and she couldn't finish the 5 days because it was very bitter, very, very nasty tasting. Kind of hard on the stomach, but it's easy to do, and it's very inexpensive. So then most of the time we'll do IV methylprednisolone or steroids, but we also have an option to do Acthar gel. Acthar gel is is adrenocorticotropic hormone, and it actually is a hormone that stimulates your adrenal glands. We have one adrenal gland on each kidney. It stimulates the adrenal glands to produce your own corticosteroids, aldosterone, cortisol, and there are others. But it stimulates your adrenals to produce a lot of corticosteroids so that your body's own natural steroids can stop the effects of the relapse itself. And it does work. Acthar gel actually has some anti-inflammatory properties, and it actually works with your immune system, and it stays in the system for 12 or so weeks. So it works longer over time. And it's very effective. Some individuals would rather take Acthar than steroids because the side effects are, in many cases, less. And it can be given in subcutaneous little needle, or it can be given in the muscle, your choice. So the symptoms of MS, you know them better than I do. I can stand up here and tell you what they are, and I will in a minute, but you guys have had them and you know what they're like. Symptoms come based on where in the central nervous system lesions occur. Lesions in the optic nerve are going to produce what? Visual changes, optic neuritis, right? Also, you can get, lesions can cause the retinal nerve fiber layer to thin out over time, and you may have decreased visual acuity, but you don't have optic neuritis. So MS does affect the vision. Lesions in the cortex here don't cause a lot of problems, except over time, it's going to cause cognitive difficulties for patients. And so that can be very profound. That's one of those silent symptoms of MS. And then frontal lobe lesions are very interesting. People who have lesions, it's very uncommon, but people who have frontal lobe lesions have problems with inhibiting emotions. They sometimes can be socially inappropriate, but those are very, very uncommon. And then lesions in the cerebellum. I have an 11-year-old grandson. He's in 5th grade. He has to learn the nervous system. I was so excited. So I said, where's the cerebellum? He knew where it was, where the cerebrum was and all that. So we were working on that last night. The cerebellum, also known as the little brain, causes impaired balance, impaired walking, tremors. It's very small, but it's very strategic in what it does. The brain stem, right in here's the brain stem, the medulla, the pons, double vision, dizziness, INO, people who have that problems with the movement of their eyes. We call it intraocular ophthalmoplegia. That's from lesions in the brain stem. And then the spinal cord, what a small area. And from the top all the way down, it gets smaller. Lesions there can be very problematic. Those lesions in the spinal cord give Patty a lot to do. A lot to do. Because if the lesion transects the cord, goes all the way across the cord, everything below that will be affected. Movement. Patients can have spasticity in their legs, weakness, bladder dysfunction, bowel dysfunction, and sexual dysfunction. Dysesthesias, painful tingling and burning. So we don't like lesions in the spinal cord. So how are we going to stop all this? How do we stop all this? That's not a hard question. What? Ursula, what'd you say? That's right. Treatment. And I know some of the treatments are hard. I had a young girl in my office the other day, and she goes, I just don't want to put those chemicals in my body. Well, you want to be in a wheelchair in 10 years? You know, your whole life can change in a flash. So when you don't take treatment like it's prescribed or recommended by your healthcare provider, you run the risk of playing Russian roulette with yourself, because the next week is unknown, next year is unknown, and you can really have a lot of disability. But with the treatments we have now, we can actually stop that process, and that's our goal. So we'd like to Patty would like to be put out of business, right? You'd like to retire? Yeah, you can just come right over and help me. So we really stress to patients the importance of being on treatment so we can stop and put the brakes on this disease. So these are the common symptoms of multiple sclerosis. You know them better than I do. There can be visual changes. There can be fatigue. Fatigue is one of those silent symptoms of MS. So there can be profound pain. We're going to talk a little bit about the types of pain that come with MS. You can have sensory symptoms. Probably visual changes and sensory symptoms are the two most common symptoms at the onset of MS. You can have elimination problems, as we talked about. Depression is a silent symptom of MS. And one of the most common mood disorders is depression in MS, and it occurs in about 70% of people. And we'll talk about that. And then, of course, the cognitive changes that come in some people, only about 50%. So there's a cycle of symptoms. You can have fatigue and depression, which may decrease your ability or your desire to exercise. Then the lack of exercise can lead to greater spasticity. It can lead to constipation. And then you can have bladder problems that impair your sleep. Sleep deprivation leads to increased cognitive dysfunction, which leads to increased fatigue. So it's a cycle of symptoms. So it's not unusual for an individual to experience 6 or 7 of the symptoms of MS, but it's very uncommon for anyone to have all of the symptoms of MS. I had a lady come into my office a few weeks ago, and she brought me a list of all her symptoms. I knew they were pulled right off the internet. Because she had every symptom known to man that occurs in MS. So she was trying to stress to me how badly she feels. So, and that happens sometimes. People really want you to understand how they're feeling. And sometimes it's those symptoms that we don't see, those silent symptoms that make you feel the worst, right? Okay, so we'll talk about some of those. The goals of symptom management, though, are to effectively treat those symptoms. One time, Patty will know exactly who I'm talking about. One time I had a young man, he was in his 30s, come into the clinic, and he was in a wheelchair. He was so spastic in his legs that he had a hard time moving. He couldn't get dressed. He couldn't transfer to the toilet very well, couldn't take care of his own self-care needs. And we tried to put him on antispasmodic medication and treated some other symptoms, and it just wasn't working, couldn't get better. His legs were painful. He had that burning pain, that pain from spasticity. So we sent him to Patty. And do you know, the next time I saw him, he walked into the clinic. And although Patty, and with her miracles, did not get rid of all of his symptoms, he improved significantly through physical therapy. And so from my experience, she's a miracle worker. I love Patty. But sometimes it's not a pill you need, but it may be some other things that you need to do, like physical or occupational therapy. But we want to give you an improved quality of life. We want to avoid those secondary symptoms, like infection from bladder dysfunction or falls from abnormal gait. Those are secondary, and that they can be a real problem for you. And then we want to target you as an individual. So the way I treat Lulu's spasticity may not be the way that I treat Laura's spasticity. We have to do it on an individual basis. One may need a little pill to help. The other one may just need some stretching and some physical therapy. So let's talk about fatigue. So fatigue in MS occurs in about 98% of individuals who have MS. Some people describe a very mild fatigue that occurs in their afternoon, and they just kind of plummet and they feel like their air is going out of their balloon. Then I have other patients who are as tired in the morning as when they went to bed the night before. They have that very profound fatigue that makes them want to stay in the bed. It can appear early in the disease, or it can appear later in the disease. Doesn't matter what type of MS you have, fatigue can occur at any time. And it can worsen with other symptoms. So if you're depressed, your fatigue's going to be worse. A worsening of your fatigue is going to cause depression. Both of those are going to cause your cognition, your ability to think and remember things, to become worse. And it becomes difficult to be physical, to do your exercises, your stretching, and then it becomes difficult for many people to work. And so that's what we talk with patients about all the time. So fatigue is a significant problem. You can have normal fatigue. I try to tell my spouses and my parents, people with MS and significant others who have a partner with MS, that you can clean your house, wash all the clothes, clean the windows, clean the pool. You can wash the boat and wash the car, cut the grass, and wash the windows on the outside of your house. And you will never have the same level of fatigue an individual does who has multiple sclerosis, because it is a very unusual symptom. We don't understand it. We don't know entirely what causes it, but it is very profound and it's very hard to treat. So all of these things can impact your fatigue. Some of your medicines that you may take for another diagnosis can impact your fatigue. So there are non-pharmacologic things that we do. Cooling techniques, the cooling vests, the drinking of cold water on a warm day or a hot day from here. There are all kinds of things you can do. Learn to conserve your energy. So we may send you to Tracy, who's an occupational therapist, and she may even come to your home and look at how you expend energy at home. So we work on those. And stress management. Did you know that stress can make you more fatigued? You know, physical stress is really detrimental to all of our physical well-being. I think I've been the last person to understand that recently, but I do, and it does impair your health. It does affect your heart. It affects everything. So then we have to address all those other causes that it could possibly be. Any metabolic problems. Is it a thyroid issue? Because thyroid can cause fatigue. Is it a hormone issue? Hormones can cause fatigue. And so we have to look at all that. Are you sleeping at night? If you're not sleeping through the night, but you're getting up 6 times to go to the bathroom, and you come in and you say, I need something to help me with my fatigue during the day, but you're not sleeping at night, we're not really helping you at all. We're just making the problem worse. So we have to look at that. And then, of course, we have to look at your medicines. Some of your medicines for diabetes, your medicines for blood pressure, your medicines for cardiac issues can make you feel tired. And some of the medicines we give you to treat MS can make you feel tired too. And, of course, we have to address depression. The number one symptom of depression is what? Fatigue. Sometimes when people come in the center, we look at them and we can't tell if they're depressed or fatigued. So we have to treat both. Or we treat one and then we have them come back. But it is hard to tell sometimes. And this time of year, and over the past 2 weeks, because it's the holidays, since Thanksgiving, I've seen a lot of people who are really, really tired, when in fact, they're probably depressed. People get depressed over Christmas, don't they? So we have medications that we do use if we can't do anything else. What is the number one treatment, though, for fatigue? What'd you say? Caffeine is good. That's good. I drink it all day. You're right. So, yeah. So she's right. Exercise is the number one intervention for fatigue, but it's the last thing anybody wants to do when they're tired. So I'm riding my bike now. My husband finally got a stationary thing for me to put my bike in so I can ride it in any type of weather. Since I've been exercising, my arthritis is better. I sleep better. I eat better. I have more motivation. I'm not as tired. So exercise is the number one intervention. And did you know Pat Coyle? Some of you know Pat. Patty knows Pat Coyle. Pat Coyle is a physician at Stony Brook in New York, and Patty and I had the opportunity to go spend a couple days with her way back. How long ago, Patty? About 15, 17 years. And she has this new theory. She said health maintenance and wellness, which includes exercise, is the new disease-modifying therapy for MS. That's what she called it. She says 50% of the care we give our patients should be on wellness and health maintenance, and the other 50% is on treatment. Patty, who said that first? Victor Robert. Some of you may remember, Lord remembers Dr. Robert. He used to always say that. But we do have stimulants, we have awake-forming drugs, we have amphetamines, and we do use them. And we're not shy about using them either because they do help. Yes?
What about emotional stress?
Emotional stress is draining, Pam. It is, it's very draining, and it does make you feel like you're tired. Very definitely. I'm president of the International Organization of MS Nurses and have been since June. And I can tell you, it's very stressful. I didn't even get a chance to talk to Patty about that. But, I'm under June's gun all the time. And so it's very stressful. So it does add a little bit of that fatigue. Okay, so what about cognitive changes? Cognitive changes can occur at any time. It doesn't matter if you have primary progressive MS. It doesn't matter if you have relapsing and remitting MS. It can occur in the early part of the disease. It can occur in the later part of the disease. Years ago, people used to say, well, if you have a lot of disability, you're going to have cognitive problems. Not true. Not true. You can be diagnosed 6 months ago and have profound cognitive problems, be a young person. So it doesn't correlate with physical disability, and it may be subtle. Most of the time, the changes come subtly. The family may not notice. Usually the family notices something. So if I ask the family, how long has it been that they started forgetting to pick up the kids at school, or couldn't help the kids with homework, or would forget to take their medicine, and they usually can tell me. So it may be under-recognized, and it is hard to treat. Do we have great treatments for cognitive changes, cognitive dysfunction? No. Dinazepril is one that we can use. That's Aricept. It's the only drug that's been, we don't use it that much, but it's the only drug that has proven in clinical trial to have any benefit at all, but it is short-lived. The best way to treat cognitive decline is what? To take a disease-modifying therapy early in the disease. Because MS is a disease of cognitive changes and physical changes, right? So we have to stop it early. So cognitive changes, the numbers you probably can't see, but I can't barely see them. 50% of people with MS will have cognitive changes. 40% they'll be very mild. 10% they'll be relatively moderate to severe. But really, the changes you can compensate for very easily with notepads, your alarms on your phones, reminders and that sort of thing. So, but there has to be compensatory strategies. So what do we do about cognitive? Well, here are the domains. I always talk about the domains in the clinic, and I can't ever remember all of them. But there's memory, there's working memory, there's short-term memory, there's long-term memory, there's visual memory, all kinds of memory. Information processing. How long does it take you to get up out of that chair in the waiting room when I call your name? That's one of the first things I look for. Problem solving. If the house catches on fire, can you quickly make a decision about what to do? That's important. Visual spatial abilities. If you're driving the car on I-4 and the cars are going on both sides of you, do you feel disoriented? A lot of people do. So they don't drive on the I-4. Some people have difficulty packing a suitcase. So some of these domains can affect little things that you do and very big things that you do. Attention and concentration. If you work in an office where the computers are going, the copy machine is going, the adding machine is going, the TV's on, some are playing a radio, and you're trying to concentrate, you can't attend. And that's a very common thing. And verbal fluency. Can't find a word. How many of you sat in my office and you dropped that word and you can't think of it? I do that too, but I'm old, so. But with MS, that does happen sometimes. And as you get older. So there are some non-pharmacologic things that we do for cognitive decline. We discuss it openly. And don't be afraid to talk to your healthcare provider or your counselor. Tell somebody about it so we can get it out there and see what we can do. And get some counseling. Not all of the neuropsychologists will do counseling, but there are psychologists out there that can, I hear you. I see you. There are psychologists. I knew that's why he walked in the room, so I was just ignoring him. So there are psychologists that do counseling. There are social workers that do counseling that can help you through it. And then there are compensatory strategies. We have a neuropsychologist in our office, David Maroof, and he's a really very sweet guy, and he's very good at what he does. And so I always say, what are the compensatory strategies? What are you going to do for this person? Because if we're going to test you and evaluate your cognition, we have to come back with some things that you can do to improve if there are options for you. Then there are pharmacologic. The disease-modifying therapies, as I said, is your best option to prevent cognitive decline. But those treatments must be done early. And then dinazepril, I probably misspelled it. But that's the only drug so far that has shown promise. Neuropsychological testing, who does that and why do we do it? Neuropsychological testing can separate the cognitive problems you're having from any other entity. Is it MS? Is it depression? What's causing the cognitive decline? And so the neuropsychologist can evaluate you and separate that, and then he can tell us what compensatory strategies and tell you what you can do to make it better. Sometimes I had 2 ladies last week. It was unusual that I have 2 in 1 week, really. They both were about the same age, same gender, same ethnicity, and they were both tired, they were both depressed, and they were both having problems at work. And they were afraid they were going to lose their job. One felt that she probably should step out for a while and reevaluate her abilities to work. So in those cases where you may have to file for disability, you may look perfect physically, you don't have any physical disability, but you have that cognitive disability, a neuropsych evaluation can make the difference in your ability to get approved for Social Security disability. So we have our neuropsychologists, but our speech and language pathologists do a very nice cognitive eval, and our occupational therapists also do one that evaluates how you function cognitively in your home. So all 3 of those specialties can actually do a neuropsych evaluation. Depression, the most common mood disorder in multiple sclerosis is depression. We don't know where it comes from. We do believe that it's part of the disease itself. I find that the more that people have lesions around the ventricles, around the corpus callosum in the cortex, that those individuals tend to be more at risk for depression. You may be happy with your spouse, you may have a beautiful home, you may have beautiful children, you have everything you've ever wanted, all the money to spend, convertible, everything, and you're depressed. We see that in the clinic because it's called MS. MS can lead to depression in about 70% of individuals. So we don't always know why it happens, but it does happen. So what do we do with it? We treat it. That's right. So I have husbands that come in, and my wife said for me to come see you. And I said, okay. That's the key. That's the key. I'm throwing the furniture, I'm agitated, I'm mad all the time, I don't know what's wrong with me, what can I do? So we treat that as a mood disorder, and we use antidepressants, and they most always fix the problem. Because people can become agitated and just anger. They punch the walls with their fists. That's part of this mood disorder called depression. So whether it manifests itself in a depressive state or an agitated state, doesn't matter. We treat it the same. So the clinical characteristics, there are a number. You feel sad all the time. You're crying. People call me and they can't tell me what's wrong because they're crying so hard on the phone. You just don't want to get out of bed. You don't want to get out of your pajamas. You don't want to eat. Or you eat too much. I eat too much when I'm sad and upset. And some people do. You don't have any energy. There's that fatigue. You can't remember anything. You can't balance your checkbook. That's that cognition's affected by depression. Those 3 are like revolving doors. And then you may manifest it, as I said, in anger, and then, of course, in suicidal thoughts. So we always ask the patient, have you had any thoughts of suicide? Number 1 question. And in this state, we're required to ask that. So if you are depressed and you go to your doctor to tell them and they don't ask that question, they should ask that question of everybody. So we look at the risk factors. We want to get it out in the open. We wanted your family, anybody in your family have depression, all of that kind of stuff. And then we talk about it, and then we treat it. There are stimulating antidepressants for those who have fatigue with their depression. There are other medications that calm you down for those that are anxious with their depression. So there's many different types of antidepressants. Sometimes it takes time to find the right one. And then we want you to go to counseling, because counseling and medication together are much better. We get a better response than either one of those by itself. So don't be insulted when we ask you to do those things. Some people don't like counseling, but don't get insulted because we're trying to do what we feel is best for you. Pain. You know, for a long time we didn't call pain a silent symptom of MS. And when I got started working in MS way back in the day, I won't tell you how many years, but doctors were saying MS doesn't cause cognitive dysfunction and it doesn't cause pain. Well, we know that both of those are not true anymore. There are different types of pain that come from MS, and it is a common cause of disability. You can actually get disability because you're so dysfunctional due to pain. Patty can fix it, though. But most MS pain is manageable. So there are acute syndromes. Trigeminal neuralgia. Anybody ever have trigeminal neuralgia? It's very painful. It's about 400 times more painful than a bolt of lightning, they say, but it's extremely painful. I have a lady now that's had it now for 2 months, and she can't eat, she can't function, and we're getting ready to send her to a neurosurgeon. Optic neuritis is an acute pain syndrome if you've ever had optic neuritis. And then some people have that Lair meets. You know, when I tell Kathy when she comes in, I say, Kathy, bend your head down. Now, do you feel any tingling, any sharp pains? And she'll tell me, because we're looking for that pain syndrome. And then there's chronic pain. The most common is that neuropathic pain in the legs or in the arms, that dysesthetic paresthesia, can't sleep at night. Your legs get restless spasms, or spasticity is very painful as well. And then there's a lot of medications that we use. We don't always use the narcotics, and I'm much more lenient about that now than I used to be. We can't prescribe it, nurse practitioners, but I do. I know, I see you. But we do use them now, and again, I'm much more lenient about it. I have colleagues that have worked for years in pain management, and they've helped me to understand the whole process. Sometimes we use those anti-seizure medications that block the pain pathways. So there are things that we can do. And then the non-pharmacologic massage therapy, acupuncture. I'm much more lenient about acupuncture as long as they're certified. Stretching for the spasticity. Go see Patty. She fixed it. Massage therapy. All of those are great things to manage pain. So whatever your symptom is, just remember this. One person can't do everything. And you need a village. It takes a village to take care of people with MS. So you need a physical therapy. You need a nurse practitioner. You need a primary doctor and a neurologist and an occupational therapist and a urologist and a psychiatrist and a psychologist and a neuropsychologist. So you need not all of them all the time. But when you need them, we bring them into your care, and then they exit. But you always have your nurse and your doctors, and your Patty. So remember that it does take others. So when we recommend that, be open to it. Now, the new DMT is health, maintenance, and wellness. There's an old Chinese proverb, and I've said this many times. And this Chinese proverb says that the body is like a house of many rooms. You have to spend time in each room to be truly well, to be truly healthy. These are the dimensions. These are the rooms here. And if one room is not organized and stable, you're not going to be happy, healthy, and well. So just remember that. And so MS is a complicated disease, and just remember that if you should be on treatment and it's been recommended, please do it for yourself. It's your security for the future. And remember that if your symptoms aren't being managed well, see your doctor about that and let them know, because there's a lot of interventions that can be done, because we want you to have hope for the future. I'm done.
Your timing is great. She only ran 30 minutes over. And she wonders why I kept coming into the room, right? So, you know, normally you'll see me out here running around bringing this mic to everybody. That, again, these cameras are not here focusing on any of you. All right, these cameras are here only to hear and see who's in this box, all right? So when we're around doing Q&A, Michelle from one side and MJ for the other are gonna go around with these microphones. We want you to ask questions. We have 30 minutes for you to ask. Actually, we have 25 minutes because this one ran over. We have 25 minutes for you to ask questions, okay? ask your questions, whatever. They're going to be doing that. I have a few things that I have to go. I got to go meet the guy on the sleigh, all right? And he's landing in a few minutes, so. All right. So anyway, again, let's just get started on that. Please speak right into the microphone. Let them get to you. The world is not going to be able to see your face. They want to hear your questions, though, and they want to hear these answers. Thank you. Here you go.
So you put up all those people that you have to go see, all the different doctors and that whole slide there and different things.
Sometimes.
Now, shame on you for not putting a nutritionist on there.
Well, we can't fit everything on there.
Oh, come on.
But nutrition was on the last slide now because it's part of health maintenance and wellness.
Okay, so that leads to my question is,
Okay.
if it's in fact that wellness, like that one doctor and many people feel is 50% maybe of the treatment, why don't more doctors' offices have nutritionists on staff?
It's very hard to bill for a nutritionist,
Right.
and that's why they don't have them, because who's going to pay them? There has to be, usually they think in terms of bringing revenue in. But there are nutritionists at the hospitals. Patty, she has access to a nutritionist because she's a hospital-based center. So every center can't afford them. That's
But how do you talk about fatigue without talking about nutrition? Because
That's
it can
true.
take your body 72
That's true.
hours to break down meat,
That's
but
right.
only 4 hours
Meat's
to break
not good
down.
for you.
Yeah, but I'm saying
That's true.
it's very
It is
critical. I don't know why people don't look at nutrition more. I had horrible fatigue. I used to sleep from 8 at night till 4 in the afternoon, and in 2 months when I switched to a plant-based diet, that
Right.
just lifted, as well as my
Right.
cognitive issues.
Right.
So.
I agree with you 100%, because I'm that regimented that way myself. Any other questions? You guys are so smart, and you're tired. I've seen you sleeping. So, but I understand that. You had to eat, and it makes you tired, slows you down.
Okay. Directly, okay. I was wondering about fatigue, because they say exercise, but sometimes I guess it's hard to find your balance of how to exercise correctly,
Right.
because like I feel I'll be exercising correctly, and then before I know it, I'll feel tingling in my legs, and I'll
Right.
sit down.
So what we do is to get you on an exercise program is we send you to a physical therapist, because they evaluate your deficits, your any level of disability, and they will develop an exercise program for you specifically that keeps all of those issues in mind. If you need weight loss, they'll help you with that too. And we don't want you to sweat. Patty says you have to exercise to sweat, exercise to fatigue. I've never quite got that concept, but she has that concept, as do most physical therapists. So that is what we do, because we don't want you going out there and developing your own plan. Many people get hurt doing that.
Yeah.
Okay.
Thanks.
Connie, you brought up something about, there was one of the slides where you got specific on the spine. Can you go back to that one point?
What
about,
symptoms are caused with lesions in the spine? Is
Yeah,
that what you mean?
I always say, yes, I have MS, but 99% of my issue is spinal.
Spinal, right. So the spine is very small, and as you go down, it gets tinier and tinier, and that's why we can't really see lesions in the lumbar spine, although we saw one the other day, but it's not common. So the cervical spine, which is the neck, and the thoracic spine, which is the shoulders down to the break in the back, is the thoracic spine. And that area is a lot smaller, but those two areas are very important. If a lesion leans to one side, so if you look at your MRI reports, it'll say posterior 3 millimeter lesion or something like that. If a lesion leans to one side, then the pathway may still be open. You may still have some symptoms in your legs, maybe a little tingling, numbness. If there's atrophy, where a pulling in of where that lesion is, you may have tremendous spasticity, even scissor gait where your legs cross. So those kind of problems can occur. But if the lesion transects, goes all the way across the cord, and the pathway is not open, it can cause multiple problems with movement, spasticity, bladder function, bowel function, sexual function. So I have a 23-year-old now. She has 2 children now, but When I first met her, she was 17. She was a high school student at Boone High School. And she had brain lesions and spinal cord lesions at diagnosis. And she had all of those that I just mentioned. And so she's doing really well now. We've really worked with her, and she's really doing quite well. But it can really impact the quality of life
Michelle.
of people with MS. And pain can be the really worst.
Okay, over here.
Hi, Denny.
I want you to ask me how I'm doing.
How you doing, Denny?
I have MS. How the hell do you think I'm doing? Just a little.
It's always nice to see you, Denny.
Does Rituxan have any place in the treatment of MS?
Absolutely. Rituxan is, let me tell you the story of Rituxan. Rituxan is a monoclonal antibody. It decreases new lesions by about 90%. But back when they were doing studies on Rituxan, had been used in Crohn's disease before it had been used in MS, and they were doing treatments for its use in MS, and 2 people with Crohn's disease died. When that happened, they stopped the study in MS, and then before they put it back out there to study further, ocrelizumab became an option. Ocrelizumab is like a step up from Rituxan, same drug, just one step up, a better. See, Rituxan is made from mouse, is it mammary? I don't know where Patty is, mammary cells. But then ocrelizumab is made from human and animal mammary cells. So it's a purer version of Rituxan. And ocrelizumab will probably be out next year. Then now we already have one other step up, which is purely human, which is ocrelizumab, something like that. I don't have the pronunciation just perfect. But sometimes before we can get a drug to market, a better form of the drug is identified, and that's what happened. Rituxan will probably never go to market for your insurance. It will just probably won't happen because ocrelizumab will be out, and then the one that's even better than it.
And what will that address? That medication?
It is specific to a certain B cell. It's a B cell mediated. MS is caused by T cells and B cells. And so it's a CD20 B cell that it affects. And it's extremely effective, very. And it's relative. I'm not going to say it's totally safe, but it's relatively safe. We're actually doing the ocrelizumab trial, and our patients are doing exceptionally well without adverse effect. I'm glad you mentioned primary progressive because I'm not sure about that. Maybe because there are 11 drugs now being studied for primary progressive, and in fact, Pat Coyle said at ECTRIMS in September that it now is the time for primary progressive MS, and she feels that we will likely have a treatment that may be effective for primary progressive. I can't tell you the 11. Because some of them are already drugs used for something else and some of them are brand new. But they're coming along. Now, fingolimod, I think, just finished a trial looking at primary progressive and it failed. So you already know that because you're one step ahead of me always. So, but we're hoping that within the next few years there'll be a treatment. But I will tell you that and I'm glad that Judy is standing there because I think it was the Gala trial. Maybe it had been a trial before that. There was a trial done by Teva Neuroscience, and they were looking at, I think it was maybe primary progressive. It must have been the primary progressive trial, which was Promise. And there was a subset of men. It wasn't effective at all in women, and majority of MS is women. But there was a subset of men who actually did well on Copaxone who had primary progressive. So we put all of our male patients with primary progressive on Copaxone. Doesn't work in everybody, but there's hope, always hope. There's one over here.
What are you thinking about the medical marijuana that's going to be approved in January for MS?
Well, I really don't think it's going to make approval in Florida. We thought it would be approved in November, and it didn't pass. You know that. So we were kind of surprised because we kind of thought it would come out. So with the medical marijuana, though, although Canada has a oral version, and there's some speculation that that will be approved in the United States. I'm not sure if that's going to happen in January, but we're open to it. So many of our patients are using marijuana for treatment. First of all, the smoking kind is bad for your lungs, and not to mention the side effects, but I know it is effective for some symptoms. But we would probably use it. I will never be able to prescribe it in my lifetime in MS, obviously. I can't prescribe Lamodal. I'm not going to be able to prescribe marijuana. But, and I've talked to Dr. Jacobs about it. I don't know how Dr. Rosenberg and Debbie feel, but Dr. Jacobs said he would prescribe it for certain individuals. We're open. We have to be open to all of it, you know. So we want our patients to get good care, so.
Okay, over here.
All right.
Connie, I'm over here.
Oh, there you are. Hey, honey.
I wanted to ask if there are more MS centers that are being formed nowadays, or
MS what?
centers, specialties, or has the healthcare system changed that away from centers?
I think that may depend on the geographical location. However, I will tell you that I was talking to some physicians not too long ago, and most young doctors do not go into MS because they owe their loans. They have to, that's their first thought, to pay their loans. MS is not a disease that makes a lot of money for neurologists. It's not a big money maker. So the young neurologists are going into things like stroke and other neurologic diseases so that wherever they can make the most money to pay off those loans. As we get older, I know there's not as many MS nurses out there now as there used to be, and as we get older and we retire, there may be fewer. So I hope that doesn't happen with physicians, but it seems to be somewhat of a beginning trend in MS. And it just depends. So.
Thank you.
Mm-hmm.
Wait a minute. No, there's one over there.
I was going off of the question that was just asked. I was kind of unclear. Are you saying there are specific doctors that are able to prescribe that kind of treatment?
Any physician with a DO or an MD will be able to prescribe a medical, if it's approved. It has to be approved and go through the processes. Nurse practitioners will not be able to prescribe it in this state.
Okay.
Ever, probably. But, we can't prescribe normal things
Okay, one here.
Yeah.
Hi, Connie. If you're off Tysabri because of a high JC virus index, is it possible for your index to come down where you can get back on it?
It's not likely that the index will change, but I'm not even sure if we know. We don't usually see a change in index, but it may be possible. Some people will be positive this month, and in 2 months they'll be negative. So we have those patients that go back from positive to negative. We usually call them intermediate, and we usually feel that they're safer than those that are always positive. The index, however, may stay the same. So it depends. If the index is under 0.9, then the chances of a person getting MS is relatively low. Some doctors would leave that person on Tysabri and then monitor them closely. And so that's sometimes what we do.
Any other questions? I think we have a visitor. If that is all, thank you very much, Connie and Patricia. Ho, ho, ho is around the corner.